So good day to you all, wherever you're joining us from. And would like to welcome you to this second webinar where we are looking at long COVID. And firstly, I'd like to apologize to those of you who tried to join the first one and couldn't, because we could only take 100 people for the first webinar. So with this webinar, we can take as many people as possible. So really the purpose is essentially a continuation from the last webinar which we held, which is really to look at long COVID. You know, we thought we were looking at long COVID just in Zimbabwe, but we do realize that we have people joining in from all over the world. So it's really long COVID, you know, from a low and middle income setting context. You know, what are the treatment and challenges that we face? And so this overview really will be on how various health disciplines are responding to long COVID in Zimbabwe and beyond. And we really want to take the first step of many in developing effective treatment strategies in the African context. As you may very well know, long COVID requires a multiple disciplinary and coordinated approach, as the symptoms are both psychological and physical. They include fatigue, shortness of breath, heart palpitations, joint chest pains, muscle aches. You know, the list is endless. You know, loss of smell and taste, anxiety and depression. You know, and it often affects multiple organ systems, primarily the heart, gut, and brain. And so the impact on functioning and quality of life ranges from mild to severe. And so we hope that by setting up these series of webinars, we will really tap into the different clinicians, the different expertise out there in terms of how people are dealing with long COVID, and hopefully use this as a platform to not only set or develop networks for long COVID in Africa, but also to consider looking at very specific cohorts over time where we learn from both the clinicians in terms of what they're doing, but also what people are experiencing, so that we can better be informed on how to provide an evidence-based approach to the management of people with long COVID. So with those few opening remarks, I'd like to first welcome Dr. Zichawo, who is going to be our first presenter this afternoon here in Zimbabwe. Dr. Zichawo, over to you.
Thank you. Good afternoon, colleagues. I'm Dr. Shelton Zichawo. I'm a general practitioner here in Harare, and I'm a co-chair of the Zimbabwe COVID-19 Frontline Clinicians Society. So I'm going to present on long COVID, general overview, and the management and the challenges which we meet. So can I share my slides?
Yes. Please go ahead.
Right, can you see my slide?
Yep, we can.
Thank you. Okay, so I'm going here now. So it's basically about long COVID treatment and challenges overview, as I said. So an introduction, I think we are aware that most people who catch COVID don't become severely ill, but significant numbers have long-term problems and after recovering from the original infection, even if they were not very ill in the first place. So the term post-acute COVID-19 syndrome, which is post-acute sequelae of SARS-CoV-2 infection, or PASC, was proposed to define symptoms and abnormalities persisting or present beyond the 12 weeks of the onset of acute COVID-19 and not attributable to alternative diagnosis. And this is basically like the terminology and definition of long COVID. We have got acute COVID, which we are grappling with at the present moment. That's up to symptoms up to 4 weeks. then anything from 4 to 12 weeks, that's ongoing somatic COVID, and what we now call post-COVID or long COVID or post-COVID syndrome is what we are seeing, which persists for more than 12 weeks. And are not explained by any alternative diagnosis after thorough investigation, and we attribute that to a result of the previous COVID infection. And this is this is a typical progress of COVID-19. Okay, we know that the mild 80%, the 20% require hospitalization, and out of that, the other 15% of the 20% might require ICU, where there's quite a high mortality. But if all this, after all this have recovered, some of them, which is not, it's estimated to be 30%, are going on to develop long COVID. And this is like the cycle, clinical course of long COVID, that's after the acute. Here we are, where we are looking at long COVID with all this multitude of symptoms, from fatigue up to hair loss. And then of these, what causes long COVID? We are not sure exactly why. Probably it's just an autoimmune response, direct viral cellular toxicity, endothelial dysfunctioning, or persistent low-grade inflammation. And it's challenging to treat something if you don't know what's causing it. That's the main problem with this long COVID. Yes, we can identify the symptoms, but what is the pathophysiology? Unless we understand the pathophysiology, it's going to be a nightmare treating these patients. So this is like a list of some of the common symptoms which you see, from fatigue, body ache, shortness of breath, all down to headaches, insomnia, anxiety, all those psychiatric problems, persistent cough, and chest pain. The symptoms of long COVID are not limited to these mentioned. There are hundreds and hundreds of which people are reporting, which are now being recognized as due to long COVID. And this is a presentation of organ-specific symptoms, like we start from the neurologic, brain fog, very, very common, loss of smell, encephalopathy, stroke, psychiatric and psychological depression, post-traumatic stress disorder, anxiety, social isolation, insomnia, stress, pulmonary, with chest pains, difficulty in breathing, cough, post-COVID, interstitial lung disease, cardiovascular, with palpitations, myocarditis, pericarditis, and abnormalities in blood pressure. We could also got cutaneous, skin, fatigue, joint pains, problems with the kidneys, pancreas. Patients end up going into diabetes mellitus. So this is predictors. These predictors, those people who are likely to develop long COVID. And it's important when we are seeing this in the acute phase that we need to follow them up, because they might develop long COVID. Like the older age groups, those with severe disease who long stay in the ICU, who needed ventilation, those with abnormal laboratory results, and then some of the underlying comorbidities like diabetes, hypertension, and obesity, and also middle-aged females and symptoms, more than 5 symptoms. And it has been postulated that probably long COVID could be due to 4 different syndromes, and this could be permanent organ damage to the lungs and the heart, and any other organ, the brain, the kidneys, and the pancreas. Then post-intensive care syndrome, we know people who have come out of the intensive care, they have their problems. Then post-viral fatigue, just like in those ordinary other previous viral infections, where you can end up with chronic fatigue syndrome. And then it could also be due to continuing COVID-19 symptoms. And it is important that recognizing which patients belong to which subgroup of long COVID and understand the pathophysiology will be important in deciding treatment which are going to offer to those patients. Another challenge is diagnosis. There are currently no diagnostic tests for COVID. Okay, so instead it becomes a diagnosis of exclusion. We have a history of someone who had COVID, he presents with all those symptoms, and then you have to exclude, by doing all this investigation to make sure that it's not something which is causing these problems, and then you label it as due to COVID, and then it becomes long COVID. Another challenge when it comes to treatments is there are no proven drug treatments, and the main focus is emerging symptoms, okay? So that you gradually increase the activity and mobility of the patient. And it is important that clinical characterization of patients with long COVID is essential to provide appropriate treatment options. So some of the things which you need to look at when you are managing COVID, obviously thorough clinical assessment and investigations to make sure that what you're dealing with is COVID is not something else. And then after you've made up your diagnosis and you've investigated, you need to close the follow-up monitoring, because we don't know for how long these people are continuing with these symptoms, and these people need to be managed until they are clear of their symptoms. And there's the requirement of palliative care, rehabilitation, counseling, and other psychosocial needs should be assessed and addressed. And obviously, there are others who might develop the more serious problems, and these they will now need to be referred to appropriate specialist disciplines. And given the diversity of symptoms, the management of these patients cannot be limited to a single specialized discipline and clinic, and it requires a multidisciplinary team approach, which is something which we really need to work on as Zimbabwe, so that we have multidisciplinary teams which are going to help this problem, which are going to help these patients. And this is like a principle of how you can arrange your multidisciplinary team approach with the primary care there. Okay, that's the first point of call. And then they will need now to refer to the neuropsychiatry and the psychiatrists and psychologists to screen for things like anxiety, depression, and all those. Then you go to also pulmonary to the pulmonologists, cardiologists, where they have to investigate the pulmonary functions and also the cardiovascular problems which may arise from post-COVID. Then also got hematological problems and endocrine problems, like those who end up developing diabetes mellitus and the thyroid dysfunction, and also the renal. And also we will need to have physiotherapists and all other disciplines which are going to assist in the multidisciplinary approach of these patients. Now I will try to come to the specific treatments of the symptoms which we are doing, okay, from what I do, what other colleagues are doing, and also what I've read other people are doing. So pulmonary symptoms, which seem to be the most common, most frequent, cough and shortness of breath, probably this will be managed by self-management by limiting factors that exacerbate dyspnea, including stopping smoking, avoiding pollutants, and exercise. And we've seen colleagues using steroids, to alleviate this shortness of breath, both oral and inhalational, and to some extent they're also using inhalational bronchodilators. Then also you have to send them to the physiotherapists for breathing exercises and pulmonary rehabilitation. Some of them come with persistent chest pains, yes, and on top of using the usual non-steroidal anti-inflammatory drugs, we have been using colchicine, and we've been getting some good results for the response from using colchicine because of its anti-inflammatory actions. And I've also read that oral opioids can be used to treat dyspnea. In cardiovascular symptoms, important that we are able to identify postural orthostatic tachycardia syndrome, okay? Well, this continues the problem itself, and this we have to be managed and referred to the cardiologists for that they can continue their investigations, echo and cardiac biomarkers. We have found the usefulness of beta blockers, which we use frequently, especially for cardiac arrhythmias, especially the tachyarrhythmias and palpitations. And they're also used in angina and other symptoms, but here we mainly use them for the palpitations. Then we've got the fatigue, cognitive and neuropsychiatric symptoms. It's chronic fatigue, self-management and supportive care, cognitive behavioral therapy. Now you have to, clinical psychologists and psychiatrists who have to manage these people along those lines. There are some medications which I've come across, but what is available in Zimbabwe, I don't know if there's, but I know donepezil is available, yes, and it can be used for that. And as they have insomnia, we use the general benzodiazepines, the clonazepam, lorazepam. Then with mental health problems, depression, anxiety, PTSD, obsessive compulsive disorder, and other mental problems. And mostly for depression and anxiety, we have been using fluoxetine. Fluoxetine, yes, and we've been getting a good response from use of fluoxetine. Then there are also drugs which are being repurposed for long COVID. Antihistamines have been indicated as a possible treatment. Yes, we also do use antihistamines in these people, patients with cough, because we might feel it could be an allergic cough, so we might try antihistamines. And as I said, we've also used antidepressants for treating depression and anxiety, but they also said they reduce effects of long COVID on their serotonin pathways of action. And again, ivermectin crops up again. Yes, we talked about its use in acute COVID, and in some studies done in Argentina, they said that using COVID actually improves, accelerates recovery of long COVID symptoms. Something which you have to look into since you're already using COVID for acute COVID. They're using ivermectin for acute COVID here. Then in the imaging therapies, okay, some of them we also having them here. So clinical trials to treat long COVID. There's use of hyperbaric oxygen. Yes, we are having some centers who are using hyperbaric. They are using it in acute COVID, but here we are seeing that it's appearing, it's being trialed for use in long COVID. Montelukast, we do use it for our allergy problems, and these are also being tried. So it's, I think, something which we need to use. This drug, dupifenidone, this is an antifibrotic for those who eventually develop pulmonary fibrosis. Also, something exciting there, vitamin C in high dose, as high dose intravenous vitamin C. Something, since this is easily available, something which you may need to try. Nicotinamide riboside is a dietary supplement. Then also issue probiotic supplements, especially for the GIT symptoms of COVID-19, the long COVID. Then with these monoclonal antibodies, these new molecules that suppress the intense inflammatory response, they're being tried. There's leronlimab, and then we've got tocilizumab, which we are using in acute COVID, and it's now appearing that yes, it can be tried in a long COVID. Melatonin, yes, I've seen some specialists are using melatonin in the long COVID patients, and it's available, it should be used. Then adaptogens, these are herbals, you know, since we don't know what's the pathophysiology, because we end up throwing in everything. So adaptogens are herbals, which, if available, can be used. So these are the long impact, the lasting impact of COVID, not those survivors. Some of these people in other countries who have been doing long follow-ups, they have found that if with these cardiovascular problems, they can care patients on and on, respiratory, the kidney injury, the general malaise and fatigue, the mental health problems, they can go on for months and months. Nervous system, metabolic, yes, like the current wave, we are seeing problems. What's going to happen to these diabetes are having very high blood sugars? Is this going to continue into long COVID, something which needs to be looked into? Then more research is needed to examine the long-term consequences of COVID-19. Because what we understand is that it can result in prolonged illness, but much is still unknown about how COVID-19 affects people over time. So we need more research and more studies, and we need to focus on things like long-term effects, why symptoms persist, and where do they recur, how these health problems affect our patients, both physically and psychologically, and their mental health. The clinical course and the likelihood of full recovery. Yes, we know most of these people are going to recover fully, but what about those who cannot recover fully? For how long are they going to continue like that? And then implication of long-term health effects on return to work, whether these people are going to return back to their normal activities. Imagine someone who's been doing complex activities and that guy develops cognitive impairment. What's going to happen to him? Is he going to regain fully his cognitive capabilities? So these are meeting the challenges. This is like from a multidisciplinary approach, what we should do, reporting, you know, we have to report these symptoms which we are seeing, and obviously having things like disease registries, proper follow-up, and then recognition, listening and believing and avoiding stereotypes, and then a research of this long COVID. So in conclusion, the long-term implications of COVID are of concern. The impact of long COVID and economic injury, psychological trauma, mental health, daily life, work, and education still looms large. Important that research continues. Greater understanding is required to reduce the strain and demand on people with long COVID and the healthcare systems. The potential problem of lingering health problems is huge, particularly in the context of the pandemic. The sheer scale of care for our patients with lingering symptoms poses a serious challenge. Thank you.
Thank you very much, Dr. Zichawo. Thank you. That was very comprehensive, very detailed, touched on a lot of different aspects of long COVID. I think particularly the fact that there's need for us to generate more knowledge, more research to better understand long COVID and how to manage it. We will not ask questions right away. We will ask Dr. Zichawo questions after we hear from Dr. Michelle Dube, who is going to be presenting next. Dr. Dube, over to you.
Thank you, Prof. Okay, so I'm a psychiatrist working here in Harare, and over the past few months, I've increasingly seen patients who come in having recovered from COVID, but now presenting with different signs and symptoms. So really, the story is so repetitive. There are people who have had asymptomatic COVID who were probably managed at home. A few of them may have ended up in ICU, but by and large, they had an uneventful recovery. And then in a few weeks to a month, they start to have anxiety. And for some patients, it actually progresses into severe fatigue, brain fog. They develop symptoms of tinnitus, sometimes weight loss, and an unrelenting anxiety. And they tend to see a lot of health practitioners. They don't often present to psychiatry first. They see their GPs a lot. They go to physicians. They get even endocrinology consults. Eventually, they land up in psychiatry as well, but it's so hard to actually accept that this thing is a consequence of the COVID they suffered from, which had been quite uneventful. And something I also happened to notice was some of these patients don't respond as you expect. They're anxious, you give them anti-anxiety medications, they develop really terrible side effects, the rare side effects. They suffer from them. So they also tend not to do as you would expect. They don't recover as you would expect on antidepressants. Then conversations amongst colleagues started up, and people are asking each other, what's your experience of using these medications, these chronic medications on long COVID patients? Is there a different neural mechanism? And why are we having some patients not responding as expected? Somebody else was seeing people with a lot of anxiety and depression, but they were not linking their current symptoms back to the COVID. And of significance, and I think Dr. Zichawo mentioned this, that once somebody is negative and we expect them to move on, so why are there all these lingering issues? Which is this conversation of long COVID, why we started this group. And on further reading, you realize that about 10% of people who recover from COVID-19 will have ongoing symptoms 4 weeks after the infection, where we'd expect that the initial symptoms have resolved. They become long haulers, and the research term for that is post-acute sequelae of SARS-CoV-2, right? PASC, that is the research term. And it affects all manner of demographics, young people, old people, people who had severe illness, or even people who had mild to asymptomatic illness. The neuropsychiatric sequelae include things like fatigue, where 55% of people still have an inappropriate level of tiredness 4 to 6 weeks afterwards, shortness of breath, particularly post-exertional, dyspnea. They can complain of chronic pain disorders, joint pains, myalgia, even chest pain. Sleep disorders and headaches occur in up to 9% of these patients. And you will hear a lot about a term called brain fog. Brain fog speaks to a slowing of the thinking, a haziness of thought, or even sluggishness. And so up to 34% of people will actually be able to perceive that they are thinking slower, unable to calculate things. Some of them have concentration difficulties, so they cannot watch a movie to its end. Memory loss can tend to happen as well in some of these patients, particularly name finding difficulties. So a doctor might end up unable to remember the name of the BP machine, right? So they keep saying that thing instead of calling it a SFIG. And it is thought that these cognitive problems are because of frontal, temporal, thalamic disturbances of metabolism. And so the recommendation is that any patient recovering from COVID really should be tested for attention, executive function, speed of information processing, as well as naming. I'll come into just now which instruments we should use to do that. Depression and anxiety are also common post-COVID. It could be two things. Just the stress of having COVID can result in anxiety and depression, the isolation, the fear of dying, but it's also very likely that there's a neuropathological change that actually happens. That's why these patients don't respond how we expect to the medications. There's no hard and fast evidence of why people are getting post-COVID syndrome. But we do know that after suffering from the other coronaviruses like SARS and MERS, people were known to develop neuropsychiatric complications. So the mechanisms could be because of direct damage by the SARS-CoV-2 to the olfactory. It enters the brain through the olfactory nerve to the olfactory bulb, and from there it can disseminate and affect the other parts of the brain, like temporal lobes and amygdala, hippocampus. But it's also thought that the cytokine storm that is responsible for the pneumonia and other organ damage really can also just cause neuroinflammation. So that's an indirect cause of damage. And lastly, it's also been shown that SARS-CoV-2 can enter neurons. And it's now thought that maybe there is some latent virus in the neurons, and eventually that causes demyelination and neurodegeneration in future. So when you come across a patient who you suspect may have long COVID, it's important that you use symptom inventories to evaluate and monitor their progression. The GAD-7 is a good validated measure for anxiety. The PHQ-9 is good for checking for depressive symptoms and tracking depressive symptoms, as well as the PTSD checklist. That will also help us track if your patient has ongoing post-traumatic stress disorder. It's good to document using the ICD-10 recommendation that you use this particular code, this U09.9 code, because it will help you standardize and compare with other physicians. Now, there's no clear etiological mechanism, so the treatment is really difficult. What we are finding is that medications are being repurposed, right? And the idea, really the goal is just to control the psychopathology, but without adding additional risk to the patient. And you should try and do a multidisciplinary management of these patients. So the selective serotonin reuptake inhibitors are very good for anxiety and depression. And even in COVID, they are the first line for depression and anxiety. And just as an aside, they are currently being investigated as one of the drugs that can be used to prevent severe severe acute COVID, it is thought that SSRIs hinder cytokine release and provide an anticoagulant effect, and therefore could be useful in acute COVID, but that is still being looked into. Then we have the anti-inflammatory agents, because it's thought that there's a smoldering inflammation in some of these long COVID patients. So what you need to do is hopefully try and use some glucocorticoid steroids like prednisone, and so that might help. But there is that disclaimer that the effect is state dependent and dose dependent. You actually need to be monitoring inflammation in these patients and not prescribing steroids as a blanket. It's only to those patients who you are picking up an inflammatory state. A few drugs are also being developed for COVID. For example, being used. So you've got drugs like atorvastatin and rosuvastatin being used in long haul patients, and somehow that is helping to improve their cognitive state. We do know that in dementia, we have been prescribing statins as a way of reducing risk, the cardiovascular risk of patients, and that has been helping dementia patients. Some doctors are prescribing statins in COVID as well. Then for the insomnia, you need to tailor it to the particular dysfunction of the treatment. Either if there's hypersomnia, you can try a short course of stimulant drugs like methylphenidate. For insomnia, a short course of the hypnotics, the zolpidem, zopiclone, worst case scenario, the benzodiazepines as well, although those can worsen the cognitive impairment. Then melatonin also can be useful. If the patient is having tension type headaches, you can try and use tricyclic antidepressants or SNRIs like venlafaxine. Or if it's a migraine type headache, then you want to use the tricyclics or anticonvulsants or beta blocker medication. Psychotherapy is key in the management of long haul COVID. All the medications that I've spoken about are on a case-by-case basis, but if you optimize the quality, the function, whatever remaining function the patient has, that will go a long way in improving their life while they are suffering from long haul COVID. So we do a few things like CBT for insomnia, or even compensatory strategies, re-establishing routines, or even retraining, cognitive retraining. The group therapy, the individual therapy are all very key to the management of patients with long haul COVID. And there is an increase in suicide risk amongst these patients. So you need to make sure you've got a safety plan in place for these patients. So the challenges we're facing with COVID is that we need to develop multidisciplinary teams, as well as clinical guidelines on how to manage it. We also need to document how patients are being managed in a consistent, comparable format. And obviously, we need to develop interventions that are more community-based and community-led rather than purely medical. So the treatment of these symptoms is not yet based on evidence that's generalizable. We need to develop a research agenda applicable to our local need and with keeping in mind what local resources are available, optimally combining the pharmacological and non-pharmacological interventions that are available locally. With that, I say I'm done. Thank you.
Thank you, Dr. Dube. So as highlighted after Dr. Zichawo presented, we will now move into Q&A for our first two presenters. Maybe I will ask Jean, are there any questions in the chat? I haven't looked at the chat.
No, there are no questions.
All right, so maybe I'll start off with the first question to both of you. You know, both of you, Dr. Zichawo and Dr. Dube, you talked about multidisciplinary approach, which is obviously critical. You also touched on having a research agenda, Dr. Dube. So my question to both of you is, from within the context of public health in Zimbabwe and beyond Zimbabwe, particularly in low and middle income settings, how do you see us providing care on a large scale for people with long COVID? How can we translate this knowledge that is coming in so that it becomes readily available within primary healthcare facilities, across the country, across communities, particularly low-resourced communities? That's my question to both of you. Maybe Dr. Zichawo, you can start.
Okay. Yeah, obviously we will need a multidisciplinary approach. It's something which you have to try to create and craft. I think to scale down this to the community level, probably if we take the approach which was taken by the National AIDS Council, when we had this problem of HIV and AIDS, that is the one way of making sure that it actually reaches to the lowest level. And if we follow and copy what National AIDS Council is. So we'll need input from the Ministry of Health and all other partners who normally assist us in doing this thing. And obviously, research is important, and research, what is needed, funding. Yes, we can do our research in our private rooms and wherever, but this needs to be coordinated, and you're probably using our institutes of higher learning and also looking for funding to go into that research. Thank you.
Thank you, Dr. Zichawo. Dr. Dube, do you want to add to that your views?
Definitely. I do agree that coordination is key in spreading this message, because right now you may even have health workers who disbelieve the existence of post-COVID-19 syndromes or symptoms. So if we have a central office coordinating the efforts to disseminate this, health workers are going to start knowing about it and actually looking for it. The production of, materials, the same way everywhere you go nowadays, you must wash your hands, you must wear a mask. That information is everywhere for all levels of literacy. We probably need to start thinking of ways to disseminate knowledge with those same materials to people who are not necessarily health workers. And then routine screening. Just asking, we shouldn't wait for people to complain first. I think there's some value to just screening anyone who's recovering from COVID for post-COVID, post-acute COVID symptoms. Okay, thank you.
Thank you, Dr. Dube. Both of you raised some very important suggestions there. I think your idea, Dr. Zichawo, of looking at the HIV/AIDS pandemic and lessons from HIV/AIDS is a brilliant starting point, actually. There's no need for us to reinvent the wheel if we can learn from what has happened in the HIV/AIDS space. And Dr. Dube, the idea of routine screening, I think really this is a step we should be thinking of seriously, particularly within public health, like primary healthcare facilities. Yeah, thank you. Are there any questions from the audience? If you would like to ask questions.
David's hand is up if you want to go. David Chimuka. You're on mute if you're talking right now.
I've unmuted now. Can you hear me?
Now we can hear you, yes.
Now, sorry, I joined the discussion very late. It's something which I really wanted to have heard from the beginning. But anyway, I only joined in the middle of the last speaker's talk. I just wanted to say my experience also in COVID, as I do ward rounds there, is that most of these patients with neurological consequences have had, if you look at their history of desaturation, these are the ones who were in the 33s, in the 60s, in the 50s, and what have you. We then give them good oxygenation, they go up to recovery. But also it is based on my experience with open heart surgery, where we actually shut down the work of the heart, the work of the lungs. And most of the time, most of these patients develop neurological symptoms, cognitive defects, and things like that. We've seen that in open heart surgery, post-open heart surgery. And it's almost like COVID, because the kind of physiological changes you get in COVID are almost like we do in open heart surgery. I just wanted you to comment. What do you think? I don't know whether you have done many ward rounds in COVID wards, but we run almost 160 bedded COVID wards. And I see this kind of neurological defects among our patients, oxygen lack, oxygen mistreatment, and what have you. Thank you.
Great intro there from Mr. Chimuka, who is one of the country's foremost cardiothoracic surgeons, for those of you who do not know him. And I would suggest from now on, before anyone asks a question, please let us know who you are. Thank you very much for that contribution, sir, Mr. Chimuka. Very pertinent. Dr. Zichawo and Dr. Dube, do you want to chip in and respond to Mr. Chimuka's take?
Yes, let me speak for myself and say I don't do acute COVID care work. By virtue of being a psychiatrist, I inherit most of my patients after they've left the ward. And of the ones I'm seeing who are presenting to my care, these critical incidents are not predominant. I'm seeing middle-aged women who were managed at home. So I want to think that means they never became hypoxic, or at least not severely hypoxic while they were at home. And yet, then they come in with massive depression and anxiety. So that's to speak on my behalf. I don't know if Doc has been seeing patients with this.
Well, from my end, I think we as primary care physicians, we tend to see mostly the mild cases. Okay, those are the ones who are following up. That's why in my presentation I said it's important to have a team approach. Okay, so that at the end of the day, we are going to be following up all those who are severely ill, the ones who are in hospital, like what Dr. Chimuka said, and those who just passed through in primary care level. So we need to work as a team and share notes, share information, and so that what should we do, not to treat these patients individually, like each but individual discipline, but to come in a multidisciplinary approach. Thank you.
Thank you very much, Dr. Zichawo, Dr. Dube. Before we move on to Jonathan and Sheila, I just would like to challenge everyone present, particularly those in the medical field, with all these challenges that we are facing, particularly the examples raised by Mr. Chimuka. Is it possible for us to start creating cohorts of people with long COVID and following them up over time to learn? Because a lot of what you are contributing, the three of you, seem to be very different, but still extremely pertinent. So maybe at some stage before we end, some thoughts on how you think this could happen, if at all we are to develop or put together some cohorts of people with long COVID in this country. And the other question is, if anything does exist already, let's learn from what exists instead of reinventing the wheel. So if there are existing cohorts that are being followed up, let's try and tap into those. I will now move on to to Jonathan to make his presentation, and then Sheila, and then we'll have another round of questions before we also get some final contribution to those of you who would like to give final contribution. Please go ahead, Jonathan, over to you.
Thanks. If we could find a way to take the image off the screen, that would be great. Unfortunately, I can't share the brilliance of Dr. Dube's previous presentation. Whoops. Okay, great. Greetings, everybody. So in the next 10 minutes, I'm going to talk about what's happening in long COVID chat rooms across the world. These are our best teachers about what health professionals are doing that is effective and not. So this is part of our treatment and challenges theme here. We're going to look at what are the treatment needs that emerge and how can we respond from both an organizational and mental health perspective. So I reviewed 22 Facebook COVID support groups, and interestingly enough, they comprised 190,000 members. Africa has groups in Kenya, South Africa, Nigeria, and we just started a Facebook group support for Africa to bring us all together. And interestingly, in a little over a week, we have over 100 members. So I'd like to share 2 excerpts that I read, representative of hundreds that I've read in Africa support groups, just to give us a feeling about what people are going through and to make that come alive regarding how we respond as a clinical psychologist and those in the psychology field. So here's the first one. And what I'd like you to do is, as I read them, I'd like you to think about what do they have in common, and also what comes up for you? What are the issues that people are dealing with? Hi, everyone. My first post on here. I'm suffering terrible dizziness. I feel like I'm on a boat bobbing along. I feel disoriented, extreme crushing fatigue, brain fog, and confusion, plus many other issues. Has anyone had any success in treating the dizziness and fatigue, please? Anything whatsoever? It's been nearly 6 months, and I hardly leave the house these days. Thank you. And now let's go to the second one. Guys, I am totally at the end of my rope today. I feel like I've seen all the specialists, and no one even knows what is causing my symptoms, let alone how to treat them. I'm 17 months in, and things are getting dramatically worse. My vision feels like everything is in slow motion, and my brain feels like it's shuddering or something. I am just so exhausted of all this. I don't understand why it's getting worse, and am losing hope that it will get better. So what are some of the things that come up? Perhaps you want to write it down or just think for yourself and also bring them up in the question period. So some of the things are multiple specialists, often lack of treatment coordination between specialists, unexplained and treatable symptoms, untreatable symptoms, significant disability. These people can't work and they're housebound, and a sense of helplessness, anxiety, depression, and very importantly, isolation. So I want you to keep that in mind as we go through this. What I'm going to do is just start from an organizational level, which is what's our model? Because as everyone has said before, it's multidisciplinary. So how do we do this in a coordinated, effective fashion? So one possibility that's been bandied around is the idea of treatment networks. So in the African context, social ties, family ties are strong. So why can't we have multidisciplinary ties? This is an idea that's been coming through different African groups and also in the UK. So these would be groups of health professionals who coordinate and communicate with one another. In fact, this panel is an example of a potential treatment network. You have 4 major disciplines here, and we all talk to each other about cases that pass through. This is a possibility. They can expand nationwide at minimal cost, except for training, and unite government and private health professionals. Now, Dr. Melissa Heitman, the clinical lead for post-COVID services at the University College of London Hospitals, she also uses education and data apps to keep all the information coming. She has weekly Zoom meetings with other areas to provide supervision, so we can do that. And primary care physicians, GPs, are the first line, and also they receive intensive training. So I guess one of the questions is, if we had this idea about mobile treatment networks that are informal and formal, who would coordinate treatment in each of the networks so that we can ensure that our clients or patients get effective treatment. So a question to all of you are, what are the other models of health delivery we can use? I'd also just like to, I noticed some questions coming through on the chats and just mention something. There was, because we're going to go back to the excerpts. There was a question about children. Children can certainly get long COVID. In a study in the UK, 17,000 children, 8% prevalence rate for long COVID among children who had COVID. Okay. And supposedly the Delta variant, there's some data coming out that that's even more invasive for children. So we come back to a person with long COVID who's come into your office. What does a person do when there seems to be no cure? And when we as the treatment providers don't know the cause? We're both in a bind. So what can we do? John Kabat-Zinn, the developer of mindfulness stress reduction, says pain is inevitable, suffering is optional. So how do we reduce suffering for our clients and our patients? As some of the speakers had said earlier, just listen and believe. What happens when our patients don't fit into our model of illness? We use a biomedical model, basically, looking at the biological aspects of our patients. But what happens when symptoms don't make sense to us? There have been over 200 symptoms identified for long COVID in a 2020 University College of London study of 3,762 people in 56 countries, 200 symptoms. So if we can't find an explainable cause, it isn't all in the person's head. So what can we do? We help normalize their symptoms, that this is part of long COVID, and that their anxiety and depression is related to what is happening to their immune system. Their body is under attack, as we saw from the presentations from Dr. Dube and Dr. Zichawo. The second thing is a person is more than their symptoms. So we need to focus, as Dr. Dube said, on their quality of life. How do they find meaning in life? When you're exhausted, what do? When you can't sleep, what's the meaning in your life? And what is the purpose in their life right now, in your life, for those of you who are listening with long COVID? It can be something small. It can be watering a flower and watching it bloom. That's what keeps some people going, in my experience. The other issue is a loss of control and failed expectations. What do you do when you can't get better? What do you do when you get a negative PCR test, but you still have COVID symptoms? What do you do when you have mild or asymptomatic COVID and you get hit with long COVID? And what they found from the research is that there's no correlation between the severity of COVID and long COVID. You can be asymptomatic or mild and still get significant long COVID. So what does that do to people? Who are you when you can't walk or you can't work? What happens to you? So I just want to show you something to explore that. I hope everyone can see this. This is us. We're kind of bloated or expanded by our achievements, what we think of ourselves, what other people think of us. But then long COVID comes along. COVID and long COVID comes along. And suddenly we can't work. We can hardly walk. Each day we wake up like a truck's hit us. We're weak, we're dizzy. And all we're left with is this, ourselves. That's it, not much, just maybe even asking God a whole bunch of questions. But in this, we have an opportunity. It's called post-traumatic growth. When everything is taken away from you, what's left? And this is an opportunity to discover who you truly are without all the bells and whistles and distractions, and what is important in your life. And what you discover can never be taken away from you. And then in your life, when you return to regular life, if that happens, hopefully you'll all see it as just additions, external stuff. That really is something you do, but it doesn't take away from what you discovered about yourself. The other thing that's a major issue is isolation. So we really want to encourage people to join support groups, connect with family members and other friends. Very, very important. It keeps coming up over and over again, because when we get sick, maybe out of shame, out of disappointment, out of helplessness, we tend to isolate ourselves from everyone else. So whatever we can do as health professionals, as friends, see whether we can reverse this trend. And then just what are guidelines for each day? And this is a cognitive behavioral therapy approach that I've been putting together over the years, and other practitioners have been doing versions of this. So the first thing is letting go. We have to let go of who we thought we were and what we thought we could do. So the motto is, what you can't control, you go with the flow. Long COVID is like a riptide. It carries you along. If you resist a riptide, you can drown. If you resist, it causes pain. So the idea is just to go with it. Look at what you control and what you can't. You can only control what is now, this moment. That's it, nothing else. Your energy is limited. So don't waste energy and time trying to control the future. It's not going to happen. It's only the present you can control. So put your focus and energy on that. Then there's that sense of hopelessness or panic, waking up each day feeling like a truck ran over you, dizzy, weak. This is the hard one. Stop fighting it. Stop running away from it. For now, just sit with it, accept it. This is where you're at. When you accept it, you will find that the desperation and panic will ease. The next one is be aware of your energy levels, your debits and assets. Be aware what increases your energy and what sucks it dry, and try to minimize what sucks it dry. And remember that mental energy and physical energy are all the same. Thinking will drain you the same way that walking will. So you really need to protect your assets, your resource of energy. Finally, calming your immune system. This is an immune system disorder. So calming your mind and calming your immune system. What our mind thinks, our body believes. An example of that is, I'd like you all to think now of a wonderful warm day, perhaps being in a beautiful forest or being by the beach, listening to the wind going through the trees if you're in the forest, watching the waves and just hearing the sound of the waves coming in and out, and feeling this wonderful sense of peace. Perhaps in just this 5-second monologue I gave you, some of you already feel parts of your body relaxing. And this is a great example of how what our mind thinks, our body believes. You think about the beach or being in the forest, your body responds as if you're really there. So this is the field of what they call medical visualization. Think of calm, think of beauty. There are many apps for you. Calm app, Insight Timer app, Headspace. There's the saying, calm mind, calm body, calm body, calm mind. Right? This is what we're aiming for. So in summary, our mission as health professionals is to help patients cope with their sense of loss of control, isolation, and helplessness. It can be done, all of you who are experiencing that now. It can be done. Help them find ways to boost their immune system and physical response. So Sheila Mielke will be talking about how to boost the body and its physical response. Managing symptoms by working with the body and mind together. They're not apart. They interact with each other, okay? And that's the challenge. We don't do the mind separately. We don't do the body separately. They talk to each other constantly. And finally, our mission is to work with the whole person to improve their quality of life. So on that note, thank you very much for listening.
Thank you, Jonathan. Thank you. Really great. I like your insights on letting go, in realizing that, you may be a different person after COVID. Yep. And also going with the flow, very important key lessons that you touched on. I would like to now move on immediately to Sheila, and then we'll come back for questions for both Jonathan and Sheila. Over to you, Sheila.
Right. Hello, and thank you for giving me the opportunity to speak here today. I'm a physiotherapist that works in Harare, mainly in musculoskeletal disorders and lymphedema. I've taken an interest in COVID. I have a son researching in the States about it. I have experienced the illness, and I have a sister who is currently battling long COVID. So apart from the professional side, I do have a little bit of intersect with that. So I'd like to share my screen now, please.
You can go ahead and press share screen and it should pop up.
Yeah. No, sorry, I've lost the, there we go.
Yeah, there it is.
Okay, thanks. Let's just make it bigger. Right. Sorry, I've hopped a couple up. So just a couple of almost disclaimers here. This presentation comes with a physiotherapist's bias, and I cannot emphasize how important occupational therapists are as well in the physical rehabilitation of long COVID. With their intersect of physical and mental health interventions, they're very helpful. We have a bit more to offer on the respiratory side, and then of course the exercise side. I've relied quite heavily on research about ME and chronic fatigue syndrome, as there is very little out about how to directly approach the long COVID problems in physiotherapy. And I want to give thanks to Darren Brown in the UK for his insights as a physiotherapist and as a person living with long COVID. He has really helped a lot of us physical rehabilitation practitioners to understand a lot more about this. And above all, recognizing that often the peer support is what really helps, and the feeling that we do need to get our information out into peer groups rather than in our often quite isolated as opposed to multidisciplinary settings. Dr. Zichawo looked through a definition of long COVID, in that it continues for 12 weeks or more and is not explained by an alternative diagnosis. I just want to say here that often the sort of people who don't have the relapsing and remitting and intensifying long COVID often take more than 12 weeks to get over a moderate to severe encounter with a COVID-19 infection. And I was certainly one of those. I did not relapse at all, but I know that I only got my energy back round about the 4 to 5 month mark. And papers in the UK seem to suggest that people who've had a fairly severe bout, but not hospitalized, even home managed, can expect to regain about 15% of physical function per month. So that is very slow, and that's not considering the sort of whole long COVID constellation. So long COVID has been characterized by people who are living with it as prolonged, multi-system involvement, significant disability, episodic, unpredictable, relapsing and remitting, and individualized. No knowing how long it's going to be going on for. They are finding in studies that most people are eventually entering a recovery from the long COVID. But this could be anything between some months and, as so far, some people over a year already. Some of these predominant symptoms I mention here because we can, in our physical rehabilitation interventions, help with some of these, have approaches that can help with some of this. So the fatigue, which is often not helped by rest and really crushing. post-exertional malaise is an increasingly common finding, where I'll go into that a little bit more in a moment. The respiratory problems, the breathlessness, cough, breathing pattern disorders that can contribute to exhaustion and to reduced clearing of the chest of excess secretions. Neurological, the brain fog, headache, and sleep disturbance. Exercise can feed into these, but again, I'll come into that in further discussion. Psychological and psychiatric problems with depression and anxiety being so predominant. Again, there are a couple of physical techniques, progressive muscle relaxation and exercise therapy, graded physical activity, which can help with those. And the musculoskeletal problems that all us physios kind of resort to. Yeah. This post-exertional malaise, it's increased symptoms after any type of exertion, as Jonathan mentioned, mental or physical. The symptoms can be anything, but commonly include fatigue, worse breathlessness, increased pain, nausea and dizziness. The onset is immediate or within 24 to 72 hours after activity. Recovery can take days, weeks, or months. And so we certainly don't want to push people into this post-exertional malaise situation. A useful self-reporting tool is the Dube symptom questionnaire. And if it is present, it definitely indicates the use of pacing and or heart rate monitoring as primary physical rehabilitation approaches, way above graded exercise therapy. The physical rehabilitation interventions that we use, pacing, always symptom contingent in long COVID. I'm referring to this here as opposed to quota contingent, because as physiotherapists love to set goals and have targets and move people on and increase things. But in this type of pacing, we're very much working under the patient's symptoms. Heart rate monitoring is very useful for people to know that they're not exercising into over above their anaerobic threshold, and thereby making it more likely that they are going to worsen their symptoms. But it is technical and it is costly and requires a lot more training than pacing, which can be very much self-managed with some useful online tools. Respiratory retraining, other things that are helpful in long COVID is to learn to breathe properly, to make the best use of what you have functioning there. Using the active cycle of breathing techniques to move secretions and to get control of the breathing. And postural drainage and relief positions can be used to conserve energy and move secretions during these during trying to undergo pulmonary rehabilitation. Progressive muscle relaxation, very nice for muscle pain, but also just, again, conserving energy and learning to, and benefiting as well from the good effects on anxiety and depression. Again, something that can be easily self-taught online, just need some direction in the right, to the right resources there. Ergonomic education can help, again, with energy conservation for the person. Muscle and joint pain relief techniques can be helpful in cases of joint pain and headache, particularly where the headache is cervicogenic. Autonomic conditioning therapy has been held, is being found to be fairly helpful in some of these autonomic dysfunctions. And that really consists of a very gentle start with movement and gentle stretches and a very gently progressed move into aerobic exercise. And then right at the end, I've put what is often our physiotherapy favorite is graded exercise therapy. But this is increasingly being actually left off guidelines altogether because so many people do have cardiac contraindications or post-exertional malaise. And in those situations, you definitely resort to rather pacing and heart rate monitoring and respiratory retraining. Do not use the graded exercise therapy as a first line. So sorry for that, physios. We need to put away those targets and those increases and go back to pacing. So just an emphasis on that. Post-exertional malaise, cardiac contraindications, our good intentions could have unintended consequences. We don't want to go there. A little bit more about pacing. The idea is that all your activities, physical and mental, should be carried out in small, manageable chunks with periods of rest or relaxation in between. And that period of rest or relaxation will vary from person to person, what is needed before they can resume another small, manageable chunk. It's really important to stop any activity before there is worsening of fatigue or other symptoms. It's an important self-management tool that gives people some bit of agency over what they can, how they can get through a little bit more each day by this technique. And the strategy is to help people live within their energy envelope and minimize the post-exertional malaise, increase the quality of life and decrease symptoms very gradually. And as said before, we use symptom contingent pacing as opposed to quota contingent. A couple of case studies that point out some of this. A previously healthy 47-year-old male with a home-managed bout of moderately severe infection. 3 months later, oxygen saturation levels were still dropping if he wasn't using oxygen therapy. He was breathless on activity, and then he developed quite severe chest pain. Cardiac testing was all clear. His lung X-ray at that stage, 3 months later, showed a lot of widespread damage. He had had no idea there had been such damage. So with him, he had a slow recovery with respiratory pattern and control retraining and gently graded exercise therapy. He wasn't having post-exertional malaise, and his heart was okay for this. In another case I've seen, this was an obese, deconditioned 44-year-old male who had a severe bout of acute infection with hospitalization, oxygen therapy, and a secondary lung infection. There was no information about his cardiac function, and he could not afford further testing. 5 months later, he was still experiencing severe fatigue, breathlessness, and excessive lung secretions. So his treatment on the physical rehab side included respiratory pattern correction, active cycle of breathing techniques, and symptom contingent pacing advice. And a third was a formerly fit and active 57-year-old female, a known asthmatic with a history of chest infections. She had a moderately severe acute infection, which was home managed with telehealth advice to nebulize with a bronchodilator and a mucolytic agent. That was followed by 5 months of fatigue, weakness, sleep disturbances, breathlessness, chest tightness, and cough and excess secretions. There was no cardiac impairment assessment done at any stage. She really was hands-off managed, not in Zimbabwe. Home treatment included respiratory retraining techniques and gently progressed self-guided physical activity. And she turned a corner at 5 months and has recently managed to get back to her mountain biking. So, challenges facing physical rehabilitation is this need for individualized treatment plans, that there are very few of us, in fact. There's a very limited health service infrastructure, minimal evidence for interventions at this stage, a limited understanding of long COVID amongst us physical rehabilitation service providers. This need for rehabilitation to be in a multidisciplinary setting is a huge challenge. It's been an eye-opener to be part of this health professions forum and realize that there are ways that we can talk to each other and make our management more multidisciplinary. Not all recommended interventions are transferable to Zimbabwe's setting. And for most people facing this problem in our setting, the affordability of a prolonged recovery period is well nigh impossible. People have to get back to work to keep their jobs. So thank you. And I'm just going to leave this up for a few seconds, just very helpful things for physios and for physios to point people towards that can be very helpful in the interventions that I've just whizzed through. Thank you.
Thank you very much, Sheila. And while you leave that up there, sorry, that's my dog in the background. A question to both you and Jonathan. You both touched on similar issues. Jonathan, you talked about creating networks and the use of technology. And Sheila, you talked about, the use of self-taught interventions or programs, which can be online. And to borrow a word that you used, Jonathan, quote unquote, you use the word operationalize. So how do you see, this and everything else that you've touched on, both of you? How do you see it being operationalized in a low resourced setting or poor resourced setting like Zimbabwe? And how do we ensure that these recommendations we are making somehow have a trickle-down effect and reach the people who need them the most, particularly in the poorer communities of our countries in Zimbabwe and beyond? That's for the two of you, and then we can open up briefly before we close. Jonathan, you want to go first?
Did I start? Okay, great. Well, actually, Prof, I was thinking about Friendship Bench. They also have a good model. So that's one of the other models that can be possibly used. I think, you start with education and awareness. That's the first thing, about long COVID. You use radio, you use phones, you use WhatsApp, you use everything at your disposal. In terms of treatment, that's more challenging. I think, once again, if you could use social media, that's part of it. If it's possible to have traveling staff, that would be the other. And also, I guess, as I mentioned, the model they're using in the UK, where in a sense, you have a center of excellence that's in a building, but here it could just be a group of people who are dedicated to long COVID and finding solutions. And then they would hold Zoom groups and training for government doctors and private doctors down in the communities. Thanks.
I don't think I have anything to add there. I'm a learner in this and appreciating the ideas that I'm coming across here.
All right. Thank you both of you for that. I'd like to ask Dr. Zichawo and Dr. Dube if they want to add onto that, and also ask Jean if there are any other questions in the chat.
Clifford Moyle has his hand up.
Clifford, go ahead.
Can you hear me?
Yep, we can.
Right. My name is Clifford Moyle. I'm into research, into medical research as an amateur, and I'm also a long hauler. Forgive my brain fog. I do have a question and a contribution. The question is, Dr. Jonathan had a very wonderful presentation, and I was asking, because I got to join this forum purely by mistake. And that means there are hundreds, maybe thousands of others that didn't have an opportunity to get to such a forum. So is there a way or a place where information about COVID clinics in Zimbabwe, long COVID accepting doctors, because there is a stigma to this as well. I've been treated by 3 doctors and all of them have been saying it's all in your head. So they are deniers. They don't believe in COVID. So is there a network of doctors? And if so, where can they be found? Is there a group, a Facebook group? I'm in Zimbabwe currently, Bulawayo to be specific. And is there somewhere we can find doctors who are treating actively long COVID patients? And I have a contribution. It is to the previous doctors that contributed before. In my field of research, what we have actually found is interesting. 20 to 30% of the population infected by COVID get to suffer from long COVID. It is also an interesting fact that there's a disease called MCAS, mast cell activation syndrome, and 20 to 30% of the world population also suffers from MCAS. So there is a correlation between long haul sufferers and MCAS. And as the more that connection is being formed, the more you begin to realize that even the medication that is being used to treat long COVID are the ones that are used to treat MCAS. And MCAS presents itself as a disease that affects almost every part of the body. For some, it's a rash. For some, it's a cough that never ends. For some, it's depression. For some, they can't breathe. It's purely an immune disease that is, the immune system is actively responding to what it thinks there's still a threat. Again, forgive me for the brain fog. So there is that correlation. And with MCAS, 70% of the population that suffer from MCAS are women. And that is what the psychiatrist says as well, that most of her patients are middle-aged women, and men are coming in every now and then. And so we are finding that people, the cytokines, the cytokine storm that happens to somebody as long COVID.
Sorry to cut you. Can you conclude in the next minute?
All right, I'll do so. So that's my question and my contribution. Is there any way we can get such assistance physically, practically here in Zimbabwe? What are the doctors? Where can we find them? Thank you.
I don't know if Dr. Zichawo, Dr. Dube want to comment on MCAS and any other doctors who are on this platform. I personally am not familiar with MCAS. I'm assuming it's an abbreviation. But if anyone would like to contribute and respond to that, please do so. I see several hands. There's Dr. David Chimuka, there's Mona Lisa. Do you want to go?
No, is Dr. Chimuka here? I just wanted to put a contribution, not to answer his questions at all.
Well,
but
go ahead.
Do you want my questions and my request?
Please go ahead.
Yeah, I wanted to say, we are treating a lot of complicated COVID in our units here. As I told you that we have about 280 beds of COVID, both at Paranyatwa and at Arundel Hospital and in Bulawayo. Now each patient, when we discharge them, we ask them to come back every week to report to our outpatients department so that they can be reviewed. Now I'm asking if there's a young lady, young man who is interested in making a research project, he could visit our clinic at Arundel, make a good proposal, and then we can allow him to interview patients and write something which can be useful to Zimbabweans in terms of post-COVID treatment. And of course, she must be intelligent, he must be intelligent to prescribe something to our patients. We see an average of about 38 patients in our outpatient department following COVID. So it's a very good source of research for our own people here. Also, I wanted to mention to our lady who presented on physiotherapy, we were very aware of the role of physiotherapy. And so we ordered a lot of equipment, which cost us almost $100,000 so that physiotherapy could be used on this patient. If she could come and help us set it up for these post-COVID patients. And my question is about what is the role of diet in relieving long COVID in terms of demyelination, which we have heard that it sometimes happens to these patients. Thank you.
Thank you, Mr. Chimoka. Very good contributions there. So firstly, on your first one about doing research, you will hear from Biggie, from AMARI. Definitely AMARI will be interested in doing this. AMARI is the African Mental Health Research Initiative. But if anyone else is interested, certainly they can join us. But we will definitely be getting in touch with you. And on the issue of working with Sheila, I think that's, well, a network is already being set up here. So Sheila, maybe you might want to respond to that, how best you can help them, and anyone else wants to chip in on that, particularly on the nutrition issue, which I cannot respond to personally.
Right, I can't speak much to the nutrition issue either, but I know a lot of there are some very good resources out there about nutrition post-COVID to try and get those people's immune systems more on an even keel. So yes, worth looking for those resources, and maybe that's something that can be included in a further discussion online. Let's get a dietitian with an interest in long COVID to be talking there. And as for Dr. Chimuka's suggestion of the, I'm not sure what that equipment would entail at Arundel, but I'd certainly be open to seeing how it can be well used. Yeah.
Thank you, Sheila. Any other comments, questions, final contributions? Jonathan?
Yes, thanks. Yeah, thank you very much. I just want to mention to people that all the health professionals are welcome to the Health Professionals Forum, the Post-COVID Treatment in Africa. It's our LinkedIn group. So if you go to Health Professionals Forum, Post-COVID Treatment in Africa, you'll find it. And my hope is that we'll develop a group of doctors specializing in long COVID. We've just started that process and we're just at the first step. So all of you who are interested in long COVID and the health professions, please join us. LinkedIn, Health Professionals Forum, Post-COVID Treatment in Africa. And I think it's been listed on the chat room as well. Great, and thanks very much, Jean, for posting that. If you know people who are dealing with long COVID, as some of our listeners are, please join us on Facebook at the Long Haul COVID Support Africa group. We'd love to have you. And there we exchange information. And we also interact with the health professionals group quite a bit. Thanks, everyone.
I just want to add while you are sharing your screen, Biggie, that some of you may have noticed that it says AMARI, African Mental Health. This does not, it's not only restricted to mental health, so it's everything. We're simply using AMARI as a platform to promote and push this initiative, but it really is an initiative for everyone, including people who are outside mental health. So please feel free to utilize it. Well, it looks like there are no more further questions. Maybe on that note, we could conclude. I don't know if there's anything else you want to share, Jonathan, before we close.
I just want to thank everyone for listening and for a wonderful discussion. It's you know, I think it's very important because we keep learning. Everyone's just at the first step in all of this. So the post-COVID Treatment Network Africa thanks you, and I hope we have many more of these. And thank you, Prof, for chairing.
Thank you very much for inviting me to be a part of this. And as I said, AMARI will do everything that it can to support this network, which, by the way, for those of you who are not aware, this is being driven by Jonathan, and we are all supporting Jonathan because we think this is an important initiative, not only for Zimbabwe, but for Africa, you know, to build our own evidence, which is African, you know, contextually sort of linked. So, Jonathan, with those last words, thank you very much once again, and everybody, thank you for attending, and we will let you know when we have our next webinar.
Thank you. Bye-bye.
Thank you.
Thank you.
Thank you so much. Bye-bye.
Thank you. Bye.
Thank you, thank you, thank you. Bye.
Thank you.
Ah.